access to care, and innovations in the healthcare value chain. What are those key areas of opportunity in the health sector that you see that we can capitalize on to improve on our care delivery system and generally look at Africa's level of development as we are now? What are those key areas of opportunity that we should narrow ourselves down to that will allow for the greatest measure of impact as long as we're talking about innovations within this value chain system and access to care?
Good morning, everyone. I'll also start by providing a bit of context. I'm a director at PharmAccess Healthcare. And PharmAccess was co-founded on the premise that you cannot have improved health outcomes, whether from the public or private sector, if you have poor business processes in the organizations that provide healthcare. So what we're doing at the moment is that we're aggregating primary care providers. We work exclusively for now in the smallholder private sector space, focused on primary care providers. We have a chain of 6 clinics that we're managing, we're turning around. We're optimizing their clinical, financial, and operational processes. Like I said, with the ultimate objective of improving the health outcomes. I think there has to be a focus on primary health care, not just because I'm an ambassador for primary health care, because the truth of the matter is that 95% or more of the care that Nigerians need are primary health care services. So I personally believe that why you have a lot of people going outside the country is because primary health care is not what it should be. When people don't have faith in the basic essential services, then they tend not to also have faith in the specialist doctors that they may be referred to. And for good reason. If the primary healthcare structure is not appropriate, it means that in many instances, cases are not referred when they should be. So I would say primarily, from a service perspective, we need to focus on primary healthcare. We need to get it right. How do we get it right? I think first of all, it's the paradigm of the healthcare professionals that work in that space. Aside from the paradigm, it's also making sure that they are appropriately skilled. Some people will put the skills before the paradigm, but I will put the paradigm before the skill. Because if you have the right paradigm, then you'll make sure that you are always appropriately skilled to deliver services that you should deliver. Customer service is also imperative, and all that is paradigm, a reflection of the person's paradigm. Secondly, also, I would say is access to capital. So it may be easy for a crystal or a lagoon that have the right balance sheet, they have the right cash flow to take up loans from the banks. But for those of us in the primary healthcare space, the margins are tight. Cash flow, of course, is also dependent on our payers. And so it's pretty very difficult for us to have access to capital at the right price point. Even when we have access to capital, it is typically asset financing and not working capital directed. So we need to look at access to financing that also provides access to working capital for the primary healthcare sector space. Because if you have access to the equipment or to the assets and you don't have something to ameliorate your cash flow pressures, it's still not going to be effective. So you can buy that asset, but if you don't have money to put the right personnel there, because you don't have the right cash flow yet, then that asset is just there and it's just wasted. So we need to look at access to finance that provides working capital. I'll also say they have leadership in that space, the primary healthcare sector. I don't think the leadership has to be the exclusive preserve of any professional group. I think we need to build up the capacity of our managers to be competent managers, competent leaders in that space also. When you have the combination of the right leadership, the right management skill set, the right structures, access to capital, I think our healthcare system will be world class.
Now, what is PharmAccess doing to sell this idea of a well-structured PHC, quality care, the whole thing that you have just spoken about? How much of it have you taken time to take to government in a way that this no longer becomes the case of a few, 10 primary healthcare centers that you're working with, but becomes part and parcel of the agenda for the 10,000 that are being rolled out, so that we do have something that can have greater impact in the right manner and the right purpose?
Like I said, the primary healthcare space is the thing of the healthcare system in Nigeria, and if we get it right, it means that the objective of universal health coverage will be accomplished effectively. So what are we doing? We're focused right now on making sure that we can demonstrate the impact that we're making. So we're focused on making sure that our model of a primary health care clinic is not just a concept. It's something that I can take you to, and you can see the ambience, you can see the staff in it, you can see the way they walk, you can see the processes that have been defined, and you can also see the technology that we put in place to ensure that our records are appropriately kept, and our staff are working within confines of how they should work from a process perspective. So right now, what I should mention is that even though PharmAccess is 3 years old, we've taken over a healthcare establishment that is 42-year-old, and we are right now in the process of turning it around. So in the last 1 year that we've been at it, we've seen a lot of improvements in outpatient utilization. I think we have 50% improvement in that already. Inpatient utilization up by 33%, and of course our revenues are also up. And I've talked about all that we're doing in terms of putting our what I call toolkit in place. So there's the quality management framework, there's the capacity building that we're working on. One or two things are work in progress, like in the next couple of weeks we're going to be putting in an AMR solution. And a lot of what we're doing, we're leveraging on partnership, because that's one way to keep our costs affordable. We're not necessarily going to reinvent the wheel. So within this space, I see lots of the partners that we're working with and potential partners also. For us, it's to make sure that we demonstrate that this works. We're also making sure that we speak to others who are interested in the same model. So we're sharing what we're doing. And ultimately, we will definitely be interested in working with government.
Thank you very much. But I'd like to have your take on this question, and each one of you want to be able to get from you what are those critical capabilities that are necessary for improving healthcare value chain performance.
And if you don't mind, just let me take a minute to also respond to Olumide. I think Olumide touched on a very important thing, which is the current agenda, which is the agenda to roll out the 10,000 PHCs. And what's the role of the private sector? What's the role of everybody coming together to achieve this? I think one thing that was very important to at least what we managed to achieve between PharmAccess and ourselves with Hygiene Community Healthcare, which in my mind is a bit of a pilot, if I can call it that, for also this rollout, is what I would call the demand side. And I think the importance, the real disruption, if I can call it that, the real disruption in how to really get get the objectives achieved, was that we paid a lot of attention to the demand side. We brought the demand side to the table through an insurance scheme. And I think any universal health coverage strategy that we have for Nigeria has to be led, if I can call it that, led by a demand side financing program. So we have to see a UHC on the demand side, which is a much, much more large-scale insurance program, which will really not just help to fund the development of these PHCs, but will really be the incentive to bring all parties, whether private sector or public sector, to the table. Because there has to be, at the end of the day, a financial incentive at the table to make this not just work, but also sustain, be sustainable. I mean, like I said, from the pilot, on is what we put together. I'm glad to see, of course, Crystal felt very much part of it. So did New Era. So you did find private providers. You didn't need to convince private providers to come into this program once there was the demand, once they knew the consumer was there. And the consumer, whether we like it or not, had some financial means of coming to the table. Because at the end of the day, at the minimum, you have to make sure that there is enough funding in the system to at least keep the wheel turning, to keep all the services, keep everything. I mean, whether it was running a drug revolving fund in the Kwara State public health centers, or looking at a new X-ray machine, or whatever were the current needs to be able to serve the population. Certainly, there needed to be enough of a sort of financial viability. So, Lumide, please add that. I know you're working on it, but I think we really have to see what part of this story is going to be led from the demand side, so that hopefully we can really see enough incentive to bring all the different players to the table. And in terms of the question of what are the key capabilities that we now need to see, again, I'll draw on our experience. Certainly, yes, at the moment it is a situation where, how do I say, it's almost in the land of the blind, the one-eyed man is king. So anything you bring to the table right now, is better than what exists. But I'll be really honest, we do need to see different parts of the value chain come together. We certainly need to see much better inputs, medical, devices, medical consumables, and drugs. But we need to try and find much more efficient ways, much more efficient models of bringing each of these inputs to the table. Now, yes, on the drug side, I think we've made a lot of, shall I say, improvement with, again, managed healthcare and the HMOs really pushing, the use of generic drugs. That was something that was almost not touched on sort of 10, 15 years ago, before the health insurance market really took hold. But I think generic drugs that are of decent quality have also now become part and parcel of the healthcare system. And I think there is a role, that they continue to play, especially those that can either be locally manufactured or easily sourced, in a way that is cost effective. The last thing I will touch on is just on the actual health resource itself, as in the people, the healthcare capacity, the healthcare workers. And there is a whole conversation, and I know it's not just in Nigeria, it's much bigger in the developing world, around how do we really shift tasks down the food chain. Things that the specialist does to the doctor, to the nurse, to the healthcare worker. But I think that still is a very important, it's a key issue, that we really can manage to shift some of these tasks down to the lower, lower cost type of health worker. So, but like I said, it's all, it all has to work hand in hand. It's difficult to do only one. I know, yes, we get a lot of improvement when we do just one, but I do hope that we will be able to do at least 2 or 3, going forward. Thank you.
Capacity building within the sector is extremely key, but we also have an idea of the kind of education system we have, and it runs across board. Doctors are less skilled and less trained now than they were 30, 40 years ago. So if you're having this kind of output in terms of the medical skills that are coming out of the tertiary institution, it has a way of cascading down to the services and the skills that they're able to provide. How have you dealt with this in looking at these capabilities that we need? How have you dealt with the issue of capacity building and skills gaps?
About 4 years ago, we had one pediatrician. We had pediatrics clinic on one day. Today, we have 5. We have pediatrics clinic every day by Sunday. How we went about that was we essentially kind of networked into the residency training program, where we kind of recruited specialists from the area who would, based on their roster, come to our facility, and that has really improved our service. It is just going on to the second question as well, in terms of the gaps, there's a huge gap in specialists in Nigeria. Last week, they concluded the interview process for specialist residents in ONG at Lodz. 160 people turned up, and they're going to pick 6. So when you now start to look across all specialties, this gap is widening, ever widening. On the medical side, medical officer side, yes, the demand supply equation is not quite right, but it's more acute on the specialty side. And this is something that government needs to look into, and it's something that I think the private sector has to have an involvement in.
Most of us came here, some came by flight, you came by vehicle. But I can tell you, in the rural area, life is very difficult. The level of poverty is very, 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 very serious. And when you talk of referring a patient to any place where you have a very serious case and you think you are going to refer, most times you are just referring a dead body, because they will not even go. They don't even have the money to go. So what you try to do, you try to do the best you can, and those you can assist, you try to assist them. When this health insurance program came in, the reason many people rushed to come and register in my place, there were a lot of skills which were useful to help those people. Many of them could not deliver, they had their experience insurance. Those who needed to repair engines, they had their repair free of charge. So many people were now rushing to come and register in my place. So eventually, by January this year, when the program started having some problems, when we could not register new people, people have been coming to say, okay, when are we going to start again? And we keep telling them, be patient, they will come back and all that. So, in the rural area, the problem you have in the city, you can talk of, okay, this doctor is not good. In the rural area, you don't even have the doctors who are not good. But of course, you see, one other thing you also see in the rural area is high levels of malpractice, even by professionals. People, because of greed factor, some people want to deliver, you see them, oh, you need operation. You understand? So instead, some women, as poor as they are, instead of cutting me, let me go and deliver in that belly. And eventually they go, they deliver on their own. So the point I'm making is very simple. Practicing in the rural area is very difficult because you are very, 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 very poor people, the most wretched of beings. And even at that, a new group of people have been added to that group, those who are not receiving salaries. Yeah, for the past 2 months, some of them are not receiving it. So you are telling them to pay 200 naira, but they don't even have it. So we have a serious emergency in our hands concerning this non-registration of patients for this low insurance scheme, low income insurance scheme. So the either government does something about it, better for them.
You are founder and CEO of Drugstore, and we've been looking at the opportunities and the capabilities that are available within the healthcare chain to improve performance. One of those, you're a private sector investor in the healthcare sector. What are those key areas of opportunity to capitalize on this healthcare chain, which includes consumable companies like yours who provide services that support